It's August 16th, 2024. This is the Room Now podcast. Hi, I'm Dr. Jack Cush, executive editor with RoomNow.com. This week on the podcast, a bunch of happy things: anti-inflammatory diets, cancer, interstitial lung disease, death, dosing. Oh my goodness. Put on your seatbelt. Let's get started. A study of patients with PSA and psoriasis, mostly PSA patients, over 400 patients. They looked at the associations and the outcomes, if you will, of exercise and diet in these people. And what they found was kind of interesting. Number one, that PSA patients had more comorbidity than PSO patients. I don't know that I've ever seen that, 43% versus 26%. That when they graded the exercise level in this large cohort, the majority had really low levels of exercise. And then they went to look further at what happened in those who did exercise more than a low level. And people who were exercising more had significantly lower and better scores at DAPSA, a measure of remission and skin activity, tender joints, swollen joints, SED rates, and psoriasis extent or PASI scores. When they looked at diet, those who were adherent to a high Mediterranean, meaning anti-inflammatory diet, they were more likely to have bigger drops in their ESR and in PASI. But the only thing that panned out was high Mediterranean diet related to better enthesitis control. I found that kind of surprising, and that was significant. But, kind of reinforces some of the things we've seen before, but there is clearly a big comorbidity burden. There's clearly a need for exercise. There clearly needs to be a dietary approach to psoriatic disease. Another study on anti-inflammatory diets comes from the U.S. Biobank study, a large cohort that looked at patients who had cardiometabolic disease, diabetes, heart disease, stroke, etc., that when they showed those who were on an anti-inflammatory diet, they found that there was a significant decreased risk for dementia. And that was when you compared an anti-inflammatory diet to those that were taking sort of a Western, if not American, pro-inflammatory diet. Diet as a preventative measure in dementia, I think it's the one thing none of us want to deal with going forward because it is devastating to those affected and the families. I like this data about breast cancer that I published this week. This was a study that gathered data from commercial claims data, Optum insurance claims data, and what was called the SEER Medicare database, and found that amongst all the patients that they had who had breast cancer, roughly 17% of them had received a TNF inhibitor. So the question is, are you happy to use a TNF inhibitor in people with breast cancer? Do you worry about that? Well, clearly 17% of people didn't. And when you looked at the overall survival of people on a TNF inhibitor versus not on a TNF inhibitor and having a diagnosis of breast cancer, no different. In fact, it trended towards being a little bit lower, either 23% or 16% lower, but that was not significant, right? So nonetheless, patients with breast cancer did have better survival on a TNF inhibitor, and that was actually 72% lower or 72% better versus those that were on a conventional DMARD like methotrexate. So again, I put this up to dispel a lot of the myths we have, concerns we have about being aggressive in treating patients who have cancer. Last week we had a download on Room Now, a slide download from the recent EULAR recommendations on how to treat patients with a diagnosis of cancer and how to treat their inflammatory disorder. You can download that and see that the EULAR points to consider, not really guidelines, but sort of eminence-based, expert-based opinions based on the data, really are kind of supportive of just what I said here, that it's okay to use a TNF inhibitor with breast cancer. Speaking of cancer, how many of your patients are at higher risk. Certainly dermatomyositis, we know rheumatoid, we know PSA, probably lupus. And I found a report this week on scleroderma. And this comes from the clinical practice research database. From that cohort, they found over 1,500 patients with systemic sclerosis. From that group, 206 developed a cancer down the line. The most common cancers were mucocutaneous, so skin, and I guess oral, lung, and breast cancer were the three most common ones. What they did find was that the scleroderma patients had a significantly increased risk with an adjusted hazard ratio of 1.4, roughly about a 40% increased risk. The question is, should you then be screening your patients with scleroderma for cancer, much like many of you do with dermatomyositis? I must say, I'm not too carried away with cancer screening with dermatomyositis. I've always been reared with the data that it was more common with dermato and in men and over 50, and that good health screening measures were appropriate. So that's what I do. I do health screening measures, especially in people with dermatomyositis, and especially as they get older. And then I follow the symptomatology or the quizzical things in their history, like a cough or irregular bowel movements, and you would know what to do there. Another study of cancer this week comes from the VA administration, where they looked at a matched cohort study, and the numbers were really large. I want to say it was like 73,000 RA patients were matched against non-RA, over 600,000 people. These were older males, 63 years of age. And they found 17,000 incident lung cancers between both groups. RA patients have, as you probably know and expect, an increased risk of lung cancer. Many studies show this. The RA patients are increased risk of skin cancer, lung cancer, lymphoma, right? And those are the main ones, right? The increased cancer risk for lung cancer has a adjusted hazard ratio of 1.58 or 58% increased risk, which still persisted in people who were not smokers ever. It was a 65% increased risk, and was also found in just incident RA patients that were looked at, about the same numbers. What they did also show was from that RA cohort, there were 757 who had RA-ILD, and guess what? Their risk of cancer and lung cancer was threefold higher. So that's a little scary. So we already know that bad things happen to RA-ILD patients, higher mortality, higher risk of serious infectious events and hospitalizations. And now we can add to that list a higher risk of lung cancer. Again, a population we need to take note of, worry about, start developing some preventative measures for. A study from the Mass General Brigham looked at 172 patients with RA-ILD, followed them a mean of 6.5 yeyears. From the 172 cohort, 4% ended up with lung transplant. 26% had an ILD-related death. When they took that 179, they then grouped them by trajectory of their lung disease based on FVC. And they followed them again almost 7 years. And there were those who had no change or improvement in their FVC. The biggest group was over 50% that were a slow decline in their FVC. And I want to say that the ones that actually had a real decline, a rapid decline, 14%, those are the ones at higher risk. In those people, there was a 19-fold increased risk of needing lung transplant. And there was almost threefold risk of an ILD-related death. So again, that's sort of surprising and worrisome. The patients with a slow decline was 54%, no decline, 32%. But again, their rates for lung transplants were much, much lower. Another study looked at what happens in ILD and myositis, specifically those with the anti-synthetase syndrome. And this systematic literature review found basically there is no conclusive study or evidence that anything works at improving ILD outcomes. So this is a study of 514 patients, 2/3 were women. They did high-res CTs in the vast majority. More than half of them, or about half of them, had NSIP patterns. Half of them had JO1 antibodies, 28% with anti-Ro 52. And again, nothing worked really at improving the ILD. They had low-level improvements with rituximab in 12%, with cyclophosphamide in 17%. But again, the story is not good if you've got ILD, even with myositis due to the anti-synthetase syndrome. The Journal of Rheumatology did a nice little review of anti-Cu myositis. I must say, I'm not someone who, when I get a myositis patients, I used to never do myositis antibody testing. Maybe occasionally a JO1. Many of you will do the whole panel. And my point to that was, well, what are you going to do with the information? MI2 and Cu, and, there's a PL7 and 12 and all, again, there's a lot to know there. But the question is it going to change your therapy, or are you going to treat what they have? Well, this anti-Cu myositis study looked at, I can't remember the size of the cohort, but it was a fairly good gathering. 92% female, average age 56 years, very high levels of CK. 31%, almost a third of them, had an overlap between myositis and scleroderma. And those that did, half of them had ILD. So that's maybe one reason to do anti-Cu testing. That is potentially a risk factor for a scleroderma overlap, which would make things worse, would it not? And add in the risk of ILD. The path is pretty distinctive: myofiber necrosis, endomysial inflammation, class 1, class 2 MHC positivity on staining. So I don't know that I'm fully buying into myositis-specific autoantibodies on a large-scale basis, but I thought this was interesting. I like looking at, NXP2 and MDA5. I think that those have prognostic significance to me that's worth testing for. Sometimes we get patients who have these autoimmune diseases, whether it be lupus or Sjogren's or vasculitis, and the question is what happens to them when they get pregnant, and what's the data going to show? There's often not a lot of data. I published this week the results of the vasculitis pregnancy registry, which is a sort of open label cumulative enrollment. They reported on 147 women, 149 pregnancies. They have data on complete data on 78 of them, so about half. 36% had active vasculitis during pregnancy. That's a little scary. 14 of them were hospitalized, 4 because of vasculitis. The rest were for medical and pregnancy reasons. 74% took a vasculitis medication during the pregnancy. The good news is that 97% had live births, 21% were preterm births, which is kind of favorable outcomes given the picture I painted for you here, which is that they may continue to have active vasculitis and require active treatment for vasculitis, but the outcomes were favorable. Again, I think the challenge here is that when you have an autoimmune disorder and a patient has pregnancy, number one, consult the ACR reproductive guidelines on what you might find and about what to do. Secondly, do a literature search and find what the data is on outcomes so that you can be knowledgeable and then help guide the patient and the maternal fetal health person or the OBGYN in managing that patient over time. A recent study was published that showed obese patients have a significantly greater odds of developing gout. The odds were basically, about 70 to 85% higher than if you weren't obese, and that's really was very significant. This is a study of 600 gout patients and almost 10,000 controls, and it was looking at diabetics, and then they measured obesity in 4 different ways: waist circumference, BMI, visceral fat area, waist to hip ratio, things like that. And the bottom line is, I guess it's really diabetes and obesity significantly increases the risk of gout. Maybe it's not surprising to you, but such data isn't plentiful, and that's why I published it. Death rates were reported for the United States in this past week by the CDC in their MMWR report that and this is the death rates in the United States from 2023, where the death rates are down 6%, and that's kind of encouraging. In the last several years, we've had a significant lowering almost every year of the average life expectancy in the United States. Initially, it was due to the opioid epidemic, and then it was due to COVID. But this death rate is even down further, and the rate of COVID deaths, dropped from 245,000 in 2022, which was less than 2021 and 2020, to in 2023 only 76,000, meaning it dropped by 76%, and that probably accounts for a lot of the improvement in the mortality rate in the United States. The overall mortality rate was lowest in non-Hispanic mixed race people, about, I think it was like 300 per 100,000, and then was highest in non-Hispanic Blacks and African Americans, where it was like almost threefold higher. Speaking of death, an important study about the protective benefits of GLP-1 agonists in patients with immune-mediated inflammatory diseases and diabetes. So this is published in PLOS1, a population study from British Columbia, looked at over almost 11,000 patients with diabetes and an IMID disorder like RA, IBD, ankylosing spondylitis, PSA, etc. And they compared patients with their diabetes who were treated with GLP-1 receptor agonists versus the DPP-4I, the dipeptidyl peptidase drugs. And GLP-1s had a significantly lower all-cause mortality that was 52% better than the DPP drugs. And they all had a significantly lower rate of MACE, 34% lower. And both of those were highly significant. Again, the use of these GLP-1 drugs for diabetes is going to extend to obesity, is going to extend to improvement of cardiovascular mortality in diseases like RA, lupus, gout, and maybe more going forward. I'm going to end with a sleep study. That's the AS LEAP study, LEAP, that tested the potential benefit of dose increasing secukinumab in people who were not responding to the usual dose. So secukinumab use in ankylosing spondylitis, the usual dose is 150 milligrams sub-Q given weekly for 4 weeks and then every month. In this study, 322 is a phase 4 trial, by the way. 322 patients with AS were started on secukinumab, and then at 16 weeks, if they were non-responders, their doses were escalated or not. So at that 16 weeks, 64% were not yet responders. They did a one-to-one randomization, and at the end of, I think it was 52 weeks, there was, what was the number? Really low. People that actually achieved improvement, which was defined as an ASDAS less than 1.3. So number one, no difference between those who escalated to 300 and those who stayed at 150. Very sobering. Second, that the number of people that did improve in either group was incredibly low, less than 9%. 8.8 versus 6.7, not being significant. Adverse events, this is now a concern, now an issue if you have an AS patient not responding, whatever dose you're using. Are you going to switch drugs? Are you going to switch classes? Are you going to use another IL-17? That wasn't studied here. And switching to another class, like a JAK inhibitor or a TNF inhibitor, that wasn't studied here either. But I think this data says not much hope for sticking with a secukinumab after they haven't responded to your initial dosing. So kind of not a lot of happy stuff this week, but still nonetheless informative. And I had you on the edge of your seat. I'm sure most of you who are driving had to pull over and listen to this because of the earth-shattering news, such as the podcast. Thank you for tuning in. Go to the website to check out these citations and more. We'll talk again next week. Take good care of yourselves.